Me, Kristen, Brock, and Victor are going to talk about the basal ganglia. And so what it is, it's basically a group of nuclei that they work together to do motor function mostly, and they maintain your readiness to move. They also do goal-directed voluntary movements, and then some other things that are involved with it are postural control, sensory integration, and there's a little bit of involvement with emotion. So the 5 nuclei that we need to know are the caudate nucleus and the putamen, which make up your striatum that does input, and then your globus pallidus, which does output. And there's 2 parts to it. You have your internal part and your external. The internal is what's inhibiting the thalamus. So if you guys remember the dog on the leash, like pulling the leash would be causing it to be inhibited. And then you have your substantia nigra that is also broken up into 2 parts. You have your pars compacta and your pars reticulata. And the compacta part is what's producing that dopamine. And then the last one is your subthalamic nucleus. And then over here, I just created a little chart that has the structures and the functions. And you can see a lot of the functions have to do with some sort of motor. So like goal-directed actions for the caudate nucleus. You have your regulating limb movements for your putamen. Globus pallidus is doing voluntary movements. Substantia nigra, like I said, was doing dopamine production, but also motor planning. It also has something to do with like reward seeking and addiction. And then your subthalamic nucleus is helping select your behavior and motor action. Okay, so this is from our textbook because I wanted to pick out pictures that we didn't see in Dr. Kriminger's lecture. So you guys can pause the recording, label it, and then play it when you're ready. So I'm gonna just click through. So here's your putamen, globus pallidus, substantia nigra is this darker area here. Right above that is your subthalamic nucleus, and then your caudate nucleus is right here. And I always remember right next to the ventricles, the lateral ventricles is your caudate nucleus. And these next few slides are gonna be a little bit repetitive because they're all labeling, but I just wanted to get you guys as many different pictures as possible, just so if you get any of them on the lab exam, you'll know. So here again, you guys can pause, label it, and then click through. So here are all the labels. And these are coronal sections of the brain, so they're cut like this. And this one is further back, so the cerebellum is showing a little bit here. And on this one, the picture on the left, you can see the external and internal parts of the globus pallidus. Okay, and then this one is a horizontal section, so it's cut this way. And again, you guys can pause, label, click through. So here are the answers. And the substantia nigra is not shown in this picture, but if you guys remember from all the different cross sections we were looking at, the substantia nigra is pretty clear in the cross sections of the midbrain at the levels of the superior colliculus and the inferior colliculus. And just remember with these ones, the stainings, the colors are opposite, so it won't be showing up as dark. It would actually be white in these pictures. All right, you got it, Brock?
All right, yeah, so real quick, I'm going to hit on some neurotransmitters. So just briefly, we're not going to go super in-depth with these because they can often get confusing. So first off, I have a little figure over here on the right. I thought it was pretty cool because it kind of shows relation between the neurotransmitters that we're concerned with here in relation to the basal ganglia and the different pathways, and then some different pathologies that can result that we'll get into more detail later on with some applied clinical anatomy. But as I have over here on the left, I said we're only concerned with 4. Dr. Kriminger touched on these briefly in her lecture. I believe it's slide 9. There's a good summary of these things here. And I think what's important to remember is just the various roles that each has, whether they're excitatory or inhibitory in relation to the sort of balance of pathways. I put dopamine on both of them. Dopamine is kind of confusing. So with neurotransmitters in general, they can kind of have excitatory and inhibitory effects depending on where they're at in the brain and what pathways they're acting on. But specifically here, I put dopamine on both because within the basal ganglia, it has an inhibitory effect on the ventral pallidum. I don't know, the VP as I call it, but in turn has a disinhibitory effect on the thalamus, which we know is directly involved with these pathways that we're talking about within the basal ganglia. So a disinhibitory effect is sort of a different way of, terming an indirect excitatory effect. So I just put it on both because it can be kind of confusing, but it's all a balancing act. So don't get too bogged down and stuff like this. It's easy to get confused. So. And then here's just some more resources on neurotransmitters. They're all the 2-minute neuroscience videos are all really helpful. He's not directly talking about these neurotransmitters in relation to the basal ganglia. He's just talking about them in general, but they have the same general function throughout the brain.
Cool. All right. Let's make sure my volume is all the way up. So basically, I made these little videos to try to walk through the direct pathway and the indirect pathway. Both of them are like 3 minutes long, so I'm just gonna play it. Hopefully it works.
All right, y'all, so I'm going to try to simplify the direct pathway the best I can. So I just have a little brain drawn out here, and then I have the pathway written out in like a flow chart, so it's easier to follow. And then here's a little legend to follow along the different nuclei. So to follow the anatomy, I have your caudate nucleus here by your ventricles, your putamen here in blue, your globus pallidus here in brown, so you have the external and the internal parts, your subthalamic nucleus, which I hope is showing up on the camera because it's yellow, and then your substantia nigra, which I have split up into the pars compacta and the pars reticulata. And then I'm going to try to stick to using red and green markers. So anytime I use green, it signifies excitatory, so the releasing of glutamate, and then red will be anytime the neurotransmitter GABA is being released, which is causing something to be inhibited. All right, so basically with the direct pathway, it starts up here in the motor cortex. I'm just gonna start over here. And so it's sending signals down to your putamen and your caudate nucleus, which make up your striatum. And what's happening here is it's releasing glutamate and it's exciting your putamen to, go crazy. And so what the putamen does is that it sends signals to your globus pallidus internus and your substantia nigra pars reticulata. And so when the putamen is inhibiting this right here, your internus and your reticulata, it's causing it to not do its function. And the function of it, normally what it does is that it sends inhibitory pathways to your thalamus, so it's signaling it to suppress movement. So normally it's supposed to be there to stop movement or stop you from doing things that you don't want to be doing, like unwanted movements. But because the striatum is blocking this, it can't do its function. And so because it can't do its function, this is not happening. So nothing is stopping the thalamus, basically. Like nothing is blocking it from going crazy and basically increasing its excitability. So what happens is the thalamus goes wild and is sending all these different signals back up to the motor cortex, which then sends it to your spinal cord via your corticospinal tract. And because it's sending it's causing all this stuff to be excited, it's facilitating movement and it's increasing your activity and allowing you to move way more. I hope that makes sense.
Okay. And then I also included the 2-minute neuroscience video that I used to help me go through this. If I did not make any sort of sense, I would go back and try to watch that. And then I also included the substantia nigra pars reticulata because it was included in the charts from the lecture. But I know we focused mostly on the putamen part of the striatum and then the globus pallidus internus that's doing that inhibition to the thalamus. All right, so I did the same thing with the indirect pathway. This one is more complicated, and I mentioned it in the video. And again, this one is like 3 minutes long.
Okay, so I'm gonna try to do the same thing I did for the direct pathways, but for the indirect pathways now. Same setup with the brain and the flow chart there. Obviously some things are changed around. And this is way more complicated than the first one, so hopefully I can help you guys. But yeah, okay, so the beginning is pretty much the same. So it starts here, and I think I'm gonna do it on this side. So here in the motor cortex, it sends signals down to your putamen, and it's sending X signals to your globus pallidus externus, and this is where things get changed. So now it's going to the externus, and I'm using a permanent marker because my markers died, so I'm doing it for y'all. If my board messes up, it's all right. So sends it to the externus. Now, normally what the externus would do is it would inhibit your subthalamic nucleus, but because your striatum, like your putamen, is stopping that from happening, this can't happen, which is, as we know, disinhibition. So because it can't inhibit your subthalamic nucleus, it causes your subthalamic nucleus to become more excited. So the neurons become more excited, and it sends it to your globus pallidus internus and excites that. So if you remember from last time, the internus's job was to suppress movement to the thalamus. Now, because this is excited way more, it's causing the internus to do its job better than it normally does. And so the internus sends inhibitory signals to your thalamus. And again, like I said, it's inhibiting it more than it normally does. And because of that, the thalamus has decreased its excitation to the motor cortex and the motor neurons. So it doesn't completely stop it from doing it, but it decreases it. So I'll just do it as a dotted line instead. So if you remember from the direct pathways, the thalamus was like going crazy and doing all this activity. But in this situation with the indirect pathways, because the internus is hyped up, the thalamus can't send as many signals up to your motor cortex, so it's inhibiting your movement and decreasing your activity to move like you normally would. And yeah, I hope that helped and I didn't confuse anybody.
Okay. And then again, I included a video. So you guys can use that to help as well. And yeah, I'll mute myself out and hand it over to Victor.
All righty, talk about some inputs and afferents. So the basal ganglia is receiving that input from the cerebral cortex. You can see the projections from the premotor cortex, the motor cortex, somatosensory cortex, the limbic system, and also the intraluminal nucleus of the thalamus. So when we're talking about the inputs, the main input center is the striatum, like Mona mentioned earlier. So you see in the picture on the right, see the arrow pointing to the caudate nucleus and also the putamen. And the main neurotransmitter in this particular portion, like the inputs, we're talking about glutamate, which is excitatory. Go to the next one. Now, outputs and efferents. So the basal ganglia send those output signals to the thalamus, which eventually makes its way back to the cerebral cortex, but it can also send it to the midbrain and the brainstem as well. So the output centers for this is going to be the globus internus segment, but also the substantia nigra, which is that pars reticulata portion. So on the picture on the right, we can see arrow pointing to the thalamus, arrow pointing to the cortex, but also the midbrain as well. So that direct pathway earlier, the direct and the indirect pathways, remember we were talking about that information making its way back to the cerebral cortex so it can influence the corticospinal tracts, which then facilitates like that voluntary movement. So it can facilitate or inhibit depending on the direct or the indirect pathway. So we also want connections with the midbrain and the brainstem as well, because this helps to influence those reticulospinal tracts, which then facilitates that postural control and that postural stability. Yeah, so we can go to the next one. Yeah, so this is just a chart overlaying everything. So the top row would be the direct pathways and the indirect pathways. So going back to the cortex to influence those corticospinal tracts to aid and facilitate or inhibit that voluntary movement. And then we want that connection. We want to bring in the brainstem as well, right? Specifically the peduncle-pontine nucleus, which is going to help to facilitate the reticulospinal tracts, which then aids and facilitates that postural control and that postural stability. And then the midbrain is going to do the same thing, right? Influencing those reticulospinal tracts, and that's going to aid and facilitate walking. So the basal ganglia has many functions, right? Some of those functions being in the last column, but the main one is that readiness to move, right? Helping us to move. So in order for the basal ganglia to have all these functions, we need these connections with the motor cortex, the brainstem, and the midbrain, right? So patients who have deficits or impairments or a specific disease involving that basal ganglia are going to have impairments when it comes to all these different functions. So I have a little quiz for you guys down at the bottom, so you guys can click on that. I think it's like a little matching quiz, won't take too long. But yeah, you click on that and then we'll keep rolling. So hopefully the quiz wasn't too hard for you, but now we're gonna jump into some of those non-motor loops. So this is where we bring in the executive functioning, the cognition, the emotion, the motivation, but also some of those behavioral aspects as well. So for these systems, we're gonna see the projections from the frontal lobe and the limbic system. So for these, they have more of a dopamine involvement, right? So we're going to the caudate nucleus from the cerebral cortex mainly instead of the putamen, but we're also going to that pars reticulata portion of the substantia nigra. So you're going to see goal-oriented behaviors. You're going to see inhibition of undesirable behaviors. So the basal ganglia, the limbic system, and the frontal lobe all have like a connection. They're all integrated. So with this, it basically aids patients and aids us with that ability to discern like what's right and what's wrong. So a patient who has like a disability or a patient who has an impairment in this area, it's not going to have that inhibition. So they're going to be saying things that are off the wall. They're going to be doing things that are inappropriate because they no longer have that inhibition that the basal ganglia supplies. We're also going to bring in that learning, cognition, shifting attention, right? Helping us multitask, helping us shift between different tasks and being able to complete those at one time. Addiction and reward-seeking behaviors. So these have more of a dopamine involvement. So the basal ganglia has a connection again with that frontal lobe or that dorsolateral prefrontal cortex. So this is basically going to aid patients with that ability to like make proper decisions, right? Proper judgment. So patients who have deficits again are not going to be able to inhibit some of those wrongful behaviors, right? They're going to be saying things that are off the wall. And then also working memories. So it helps us with memories as well. So I got a little brain dump for you guys. So take a second, take out a sheet of paper or a whiteboard or whatever you guys have, and then jot down some of the functions of the limbic, oculomotor, executive, and social behavior loops. If you can't, that's fine. We'll get into it on the next slide. So here is just a chart overlaying everything. So you have the social behavioral loop, which can also be called the behavioral and flexibility and control loop. So this is bringing in those social aspects of those social factors, right? So helping to recognize social disapproval in those social situations, helping to select relevant knowledge versus irrelevant knowledge, and helping to maintain attention. The oculomotor loop, which has to bring in those eye functions, right? So it's helping us to initiate those fast eye movements or make decisions about eye movements altogether, but also spatial attention. The executive loop, which we kind of mentioned already, has to do with those goal-oriented behaviors or goal-oriented like movements. And then you have the planning divergent thinking, but also decision-making. And then the limbic or emotional loop has to do with emotion or reward-seeking behaviors, but also cognition, and that's also concerned with seeking pleasure as well. So this picture was a really nice picture in Dr. Crimger's lecture, where she was basically just talking about dopamine's involvement when it comes to schizophrenia. So altogether, this picture basically explains how you have multiple brain structures that work and integrate together that are responsible for like key processes such as like motivation and learning, but also emotion. So all these systems are not working in isolation, they're all integrated and working together. So you may have the brainstem is connected and communicating with the basal ganglia, and the basal ganglia is communicating with the thalamus and the frontal lobe and the limbic system. So all these things are working together to aid us with certain functions. And then we have the loop within the basal ganglia. So this is the dopaminergic loop. So remember, this loop has to do with the dopaminergic neurons, right? So the dopaminergic neurons are what produce dopamine. So in this particular loop, this is where we see like the deficit when it comes to Parkinson's disease. So we're going to see the issues with that specific disease in this place, right? So the dopaminergic neurons aren't producing as much dopamine, they aren't stimulating as much dopamine, which can then lead to Parkinson's. I'm gonna pass it over to Brock.
All right, so I of course had to include a quick meme just for a quick laugh. So just emphasize how it can be confusing with all the different facilitations, inhibitions, and all that sort of stuff. So we'll go ahead and go on to some clinical anatomy. All right, yeah, so I had hyperkinetic disorders. Dr. Crimger briefly touched on these also in her lecture. You know, different things go wrong. Obviously, you're going to experience deficits, you know, one way versus the other. So in reference to hyperkinetic disorders, these are characterized as the inability to stop or control unwarranted movement or stimulation initiated by the thalamus, because as she said, the thalamus has a tendency to always want to move, and it's reliant on the different pathways to sort of have a balancing act. In this instance, the direct pathway is greater than its action is greater than the indirect pathway, because we know the direct pathway facilitates movement, whereas the indirect pathway inhibits or monitors or controls movement. So on the right, that's just a quick little figure kind of showing a brief summary of hypo versus hyperkinetic. We can go ahead and hit the next slide. So quick etiology or causes of hyperkinetic disorders. So you have a reduction of indirect pathway activity, which leads to unregulated direct pathway activity on the thalamus, leading to information being received by the motor cortex from the thalamus, which I said is by default excitatory nature or wanting to move, and therefore that leads to involuntary and excessive movement. Down here at the bottom, what causes damage to the indirect pathway? So any insult to the cells of the striatum, palliastriatum, or the subthalamic nucleus, so it's infarct, lesion, etc. I found online that this most oftenly occurs due to ischemic middle cerebral artery strokes, which we know from last unit applies a large majority of the brain and is a common site of stroke. So here I got some quick videos for y'all. You can watch on your own time, common presentations of hyperkinetic disorders. So we talked about Huntington's briefly in Dr. Crimger's lecture, and then also embolismus, apoptosis, and chorea. Overall, hyperkinetic disorders are going to have coriform type movements, which if you remember, those just sort of involuntary, uncontrollable movements displayed by someone due to the lack of regulation of those movements. Also, I included Tourette syndrome. You may have heard of that. You can do some own research on that. It's more of a verbal tic, verbal and motor tic disorder that people can have.
Okay, so really quickly, we're also going to touch on hypokinetic disorders. Like Brock stated earlier, when you have deficits in this area, they can go either way. So there's a quick video that Mona is going to play really quick that just kind of displays what we've talked about in regards to Parkinson's disease.
A Parkinsonian type of gait in which the patient will have a posture which will be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait.
Okay, Mona, that's good.
So,
okay, so I just wanted to show that video that physically displays some symptoms that patients with Parkinson's disease deal with. So as we can see here, we mainly talked about Parkinson's. So, but when we talk about hypokinetic disorders, we're just in general referring to interruption in excitatory pathway that results in decreased movement. So as you can see here, it talks about directly how the motor function of a patient with Parkinson's disease will be affected as a result of a lack of dopamine production in the substantia nigra. So remember, the substantia nigra specifically is involved in motor planning, reward-seeking behaviors, addiction, and things of that nature. So when you have a lack of dopamine that's being produced, then those motor movements are not going to be as fine or communicated as well throughout the brain. And then the picture on the right just also kind of shows when there's a lack of dopamine versus in a healthy brain when dopamine is being produced. So again, this is caused by an increased indirect pathway activity. So remember, our indirect pathway focuses on decreased motor movement. So when that is working overtime, then you're going to have more of that stop, stop, stop in your brain versus with your direct pathway activity, it's going to be decreased. So they're sort of the indirect and direct are working together over time to just pretty much tell you to slow down, which causes things to be really slow. So the lesion occurs in the substantia nigra, and I just kind of put the things there that would be impacted to remind us. And remember, dopamine, it desires increased motor movement. So when there's a lack of dopamine production, then movement will not be desired. Therefore, as a result, it'll be decreased. So these are just some examples. Mainly, we talked about Parkinson's disease, and that's a really good video. Some other hypokinetic disorders I found were Lewy body dementia. So this actually has some, when it presents, it has some Parkinson's associations. And some people can actually confuse it for Parkinson's disease, which I thought was really interesting. But with more research, they found some distinct differences, but it is a hypokinetic disorder. And then you also have multiple system atrophy, which is also a hypokinetic disorder. And it also has just a collective nervous system presentation as well. So you'll see changes in speech, gait, behavior, and just a lot of different things as well. And those are references.